So I've struggled with a few different ideas or thoughts, and I think it's time to talk about them because I have more. I guess I've thought about them a lot and have a better understanding. And the first one I talked about is anecdote versus evidence, or generalizations versus specifics, or how do I know what's correct? So, to be more specific, in the medical field, we often talk about evidence, and what that means is studies. We say if you see one thing, doesn't mean much. See two things, still doesn't mean much. But you need studies to prove beyond a shadow of doubt, or rather statistically significant, that this is not due to random chance. Because you could see a lot of things that could be due to random chance. And so it's sort of trying to prove causation rather than just correlation. But I think the main issue for me is how do you deal with it when you're dealing with individuals? See, studies have lots of people, tens of thousands. Not everybody has the same outcome, but that's fine. You don't need that for a study to be significant or to know something, learn something about the body. But when you deal with an individual, an N of one, how does that come into play? Do studies apply to this person? So I'll start with a recent example of me dealing with a heart failure patient. So in the hospital, I was managing a heart failure patient. I was usually am hands off when there's another doctor, a specialist, like cardiologist managing. Because, I mean, why double the work? Plus, we don't communicate well. They have their own thing. Who knows, right? So there's a cardiologist following, and then the person's kidney function worsens. So I changed the medications around to not use something called an ACE inhibitor and to use instead hydralazine and a nitrate. Because I could titrate them, I could adjust them to increase so I could get the blood pressure down because that would be potentially helpful to the patient. The patient's blood pressure is way too high, like 130s. The thing is, it was successful. The patient started making much more urine. He was reportedly not responsive to diuretics, even with high doses of diuretics with combined diuretic therapy, wasn't working. Lasix strip plus thiazides, IV. But now he's putting out 3-4 liters a day. It's wonderful progress. The creatinine is maybe up a little bit, but it's fine. Nothing that bad. And the creatinine is just something to be used, right? You know what it is, but it's so what, right? I mean, otherwise he gets dialysis. He can't get all this fluid off of him. So the thing is, another doctor comes on and changes things around completely. They want to resume ACE inhibitors and stop the hydralazine and nitrate. And so I'm not going to argue here. I'm just saying whatever. I mean, you were the specialist. You could do whatever you do, right? And lo and behold, the creatinine went down. The patient stopped making much urine, and yeah, we went backwards. A number being better is not helpful. The creatinine being low and the patient not making urine is not a good thing. The patient making urine and creatinine going up is not great, but it's better than the patient not diuresing, not putting out much urine. And it's funny how they sort of lower it. We're like, oh, well, I just want the patient. Oh, the patient's net negative now. You're like, well, the patient was making 3 to 4 liters of urine a day. Now they're making 1.5, and you're happy. I mean, it's better than one, but basically you did the wrong thing. You're an idiot. I didn't say that. And so here's the deal. Per evidence, per guidelines, everything, everybody says ACE inhibitors are better. And I don't deny that in general ACE inhibitors are better. There are studies that show that in African Americans, hydralazine nitrates are good. But that's not to say they replace ACE inhibitors that are good in addition to ACE inhibitors. But saying ACE inhibitors are better doesn't mean you take something that's working and change it to something that's ineffective. Now, you can say that they didn't know that it's going to be ineffective, and I would say that's correct. They did not know. But my question is, why are you changing something that's working? I mean, I've changed things that are working sometimes because certain medications are bad for you. Like beta blockers. They're bad for you. They predispose you to get diabetes earlier. How is that a good thing? So if you're using it for blood pressure alone, without any other reason, I would stop it and use something else. I'm not changing it because it's ineffective. I'm changing it because it's not good for you. It has bad effects, and we could try other things first. May have to go back to it, but not if I haven't exhausted other possibilities. In this case, something was working. Why did they change it? I think it's this simplistic idea of evidence. So, what does evidence mean? What do studies mean? What do they tell us? Why do we rely on them? And I think that's the tricky part of medicine. You have studies and you have a human being in front of you. I think some doctors, at least, are coming around and realizing that because this whole emphasis on a holistic approach, tailoring it to the person in front of you. I was listening to a lecture about cirrhosis, and we still don't have great medications. But they're saying that, well, now the idea is that we should have a whole team and palliative care involved early because they could actually address the individual and see how they're feeling, right? Because there's numbers, and then there's actually how somebody's feeling, which probably matters, right? But if you're already taking account how the person's feeling, you're already treating the person, why do you go back and give evidence, studies, quote unquote, a blank check to do whatever they want? They don't know the person. It's like having people who don't know patients manage the patient. I mean, radiologists, right? Pathologists, they haven't seen a patient. They have no idea what's going on in a person's life. They have no idea the person's preferences. They know nothing about the person other than one X-ray or a CT scan or MRI or a slide with a biopsy sample. In the same way, pharmacists, they may say, oh, this is bad, but hey, I'm treating a patient here as a doctor. Gotta do something. Can't just do nothing because everything's too risky. I mean, yeah, that's correct, but we gotta try to get the person better, right? Versus just letting them die. And so that's the thing, right? The cardiologist was well-intentioned but naive. Or rather, I would say, didn't have a deep understanding of medicine. And that is, when something's working, right? It works. That's stronger than any evidence you have from a study. Because study is of thousands of people. And even though it has been evidence-based proven, doesn't mean it works on everybody. We all know that, right? I mean, we say antidepressants like SSRIs are very effective, but what psychiatrists say, yeah, they work for everybody. It just is simply not true. They don't work for everybody. They work for a large amount of people. But doesn't mean you could predict that it's going to work for this particular person. So changing something that works just to quote unquote do evidence, that doesn't make any sense to me. That's not logical. That's just stupid. And that shows you lack basic understanding. You treat a person based on what you know about a person. These details supersede any evidence from studies because the studies don't know your patient. You may want to change things that are working if they're dangerous. But if they're not dangerous and they're working, then don't change it. Because it works. That's the strongest evidence.